Medium vessel vasculitis consists of diseases such as polyarteritis nodosa, Buerger's disease, and Kawasaki disease. In this video, we're going to learn about Kawasaki disease. It is a medium vessel vasculitis and it's very common in Japanese people, and it is usually seen in children less than 5 years old, which accounts for around 80% of the cases. It is the most common medium vessel vasculitis in children, and it's also known as acute febrile mucocutaneous lymph node syndrome. The name itself tells a lot about the disease. Acute means the disease has acute onset, febrile means there is fever, mucocutaneous, so mucous membranes and the skin are involved, along with the lymph nodes. In Kawasaki disease, the most common vessel affected is coronary artery. Hence, it is the most common cause of acquired heart disease of childhood. Cardiac complications are seen in 5 to 20% of children with Kawasaki disease, and among them, the most common is coronary artery aneurysm, followed by myocardial ischemia. The cause is unknown, that is idiopathic. Now coming on to the clinical features. To remember them, I have drawn a picture here. So you can see a fire burning on the head, which indicates fever that lasts for more than 5 days in Kawasaki disease. Coming down, the eyes are red, which indicates conjunctival redness or conjunctivitis. The lips are swollen and red. The tongue is also swollen and red, for which the name given is strawberry tongue. Another disease where we can find strawberry tongue is scarlet fever. In the skin, there are superficial skin layers affected, means the skin rashes. There is skin peeling from the palms and areas around the nails, which is called as periungual desquamation. There can be red soles. Cardiac complications are seen. Polymorphic rashes are seen, especially on the trunk region, and there can also be occasional intermittent colicky abdominal pain. If you still find this hard to remember, then I have a mnemonic, that is CREAM. So C stands for conjunctivitis, which is bilateral and non-purulent. R is for rashes, that is polymorphic rashes, which is found especially in trunk areas. E stands for extremities changes like edema, erythema, desquamation of palms and sole. A is for adenopathy, where commonly cervical lymph nodes are involved, and we know this when at least one lymph node is more than or equal to 1.5 centimeter, and this is usually unilateral. M stands for mucosal changes like strawberry tongue and red lips. The diagnostic criteria of Kawasaki disease includes fever for at least 5 days and any 4 of the 5 CREAM features above. The clinical course of Kawasaki disease is divided into 3 phases. The first is the acute phase, which is the first 2 weeks of the illness, and it is characterized by fever and features of CREAM, along with increase in CRP and ESR. If no treatment is given in this phase, then the patient will progress to subacute phase, which is for 3 to 4 weeks. And in this phase, along with the features of fever and CREAM, there will be additionally thrombocytosis, that is increase in platelets, which could be due to persistent inflammation, and there can also be skin peeling. Patients at this stage are at very high risk for development of coronary artery syndrome. Hence, this is the highest risk phase. Then it is followed by convalescent phase, where the recovery starts, and it is characterized by decrease in fever and decrease in CRP and ESR. If acute phase is properly treated, then we can directly achieve convalescent phase. Other features of Kawasaki disease includes reactivation of BCG scar, perianal desquamation, hydrops gallbladder on ultrasound, and sterile pyuria on urine culture. The investigations we do are blood count for leukocytosis and anemia. There will be increase in ESR and CRP, increase in platelets, that is thrombocytosis, with decrease in proteins, that is hypoalbuminemia. ECG and echocardiography are done to find out if there are any cardiac complications. The differential diagnosis of Kawasaki disease includes measles and other viral infections, MIS-C, that is multisystem inflammatory syndrome in children, staphylococcal and streptococcal toxin mediated diseases, and Rocky Mountain spotted fever. Now finally coming on to the treatment section. The treatment of choice is IVIG, that is intravenous immunoglobulin. Single dose 2 gram per kg is given. And we should remember that taking of live vaccines should be avoided in children for 11 months after taking IVIG. For fever, we give aspirin, which has anti-inflammatory effect. The dose is 30 to 50 milligram per kg until the child becomes afebrile. And remember, children taking aspirin should also take yearly influenza vaccine to prevent Reye's syndrome. In those patients who have coronary artery aneurysms, they are at risk for developing thrombosis. And to prevent this, we need to give fibrinolytic therapy or long-term therapy with dual antiplatelet, such as low-dose aspirin plus clopidogrel. That's it for Kawasaki disease. Thank you.